morning everybody. Today's topic is porphyria. Now what are porphyrias? These are inborn errors, that is inherited diseases related to the heme synthesis. These are related to the synthesis of hemoglobin, in which there is accumulation of porphyrin and its precursors in our body. So therefore the name porphyrias because of accumulation of porphyrins. So we will see the porphyrias. Now before understanding porphyrias, what are the learning objectives of today's lecture? At the end of the lecture, the learner will be able to outline the structure of porphyrins and heme, trace pathway of biosynthesis of heme, classify porphyrias, and differentiate hepatic and erythropoietic porphyrias, enumerate the salient clinical features and management of each type. So we already know the structure of hemoglobin. In hemoglobin structure, it is a protein that is made up of the quaternary structure. So hemoglobin consists of the quaternary structure, consists of heme and globin. Now hemoglobin is a conjugated protein and it has 2 alpha and 2 beta chains in the globin part and heme attached to it. So to understand the porphyrias, we should know the type of porphyrins. So there are 2 types, type 1 porphyrin and type 3 porphyrin. In type 1 porphyrin, the groups, that is acetyl, propionyl, these are arranged symmetrically. Whereas in type 3, at the last, that is 4th chain, there is asymmetric arrangement of this propionyl and acetyl group. So this is the type 1 porphyrin and this is type 3 porphyrin. So change is here. So you will come across the terminologies type 1 and type 3 in the various heme synthesis enzymes also. So you should know what is type 1 porphyrin and what is type 3 porphyrin. So heme synthesis, heme is the most important porphyrin and it is synthesized 85% in the erythroid cells and 15% in the liver. So there are various heme containing proteins in our body and their functions are given. So to understand the porphyrias, we should first know what is heme synthesis, where it is synthesis, what are the sites of heme synthesis. So heme synthesis mainly takes place in the liver and erythrocyte cells, and also in the cells some of the pathways take place in the mitochondria while some in the cytosol. So we'll see one by one how heme synthesis occurs. So glycine condenses with succinyl-CoA in the presence of enzyme ALA synthase to form delta amino levulinic acid or delta ALA. So this first step of heme synthesis takes place in the mitochondria. Now this ALA, it enters the cytosol. In the cytosol, this delta ALA, in the presence of enzyme ALA dehydratase, forms porphobilinogen. So this porphobilinogen is synthesized and then this porphobilinogen gets converted to uroporphyrinogen. In the presence of enzyme porphobilinogen deaminase, or also known as uroporphyrinogen 3 co-synthase. So it forms uroporphyrinogen. Now this uroporphyrinogen gets converted to coproporphyrinogen by the enzyme uroporphyrinogen decarboxylase. So there is removal of carbon dioxide and this uro gets converted into coproporphyrinogen. Now these steps were taking place in the cytosol. Now this coproporphyrinogen enters the mitochondria. In the mitochondria there is the enzyme coproporphyrinogen oxidase, which converts this coproporphyrinogen 3 to protoporphyrinogen 3. This protoporphyrinogen 3 in the presence of enzyme protoporphyrinogen oxidase gets converted to protoporphyrin 3. This protoporphyrin 3 then in the presence of enzyme ferrochelatase, where iron is added to the porphyrin, and it gets converted to heme. So protoporphyrin 3 in the presence of enzyme, ferrochelatase or heme synthase gets converted to the heme. So heme synthesis takes place in the mitochondria. So the steps, that is first step and the 5th, 6th, 7th step take place in the mitochondria, whereas the rest of the steps takes place in the cytosol. So there is compartmentalization of the enzymes of the pathway of hemoglobin synthesis. This compartmentalization also helps in the regulation of the heme synthesis. So some steps we have seen have taken place in the mitochondria, while some in the cytosol. So to understand what are porphyrias, we have to understand the heme metabolism, that is synthesis, so that we will see that which deficiency causes which type of porphyrias. So we will come across these enzymes in the porphyrias to understand the deficiency manifestation. Now this regulation is at the first committed step of ALA synthase. So ALA synthase is the regulatory or committed step of heme metabolism, where the regulation takes place, and the other is, one is feedback inhibition. If there is sufficient quantity of heme, then hemoglobin synthesis will be inhibited. Repression of ALA synthase enzyme and inhibition of transport of ALA synthase from cytosol to mitochondria. Now coming to porphyrias, what are porphyrias? They are the metabolic disorders of heme synthesis characterized by increased excretion of porphyrins or porphyrin precursors. So majorly they are classified into two types, that is erythropoietic and hepatic, depending on the sites where the enzymes are deficient. So if the enzyme deficiency is present in the erythrocyte, it is known as the erythropoietic type of porphyria. Whereas if the enzyme deficiency is present in the liver, it is known as hepatic porphyrias. So these are the majorly two types of porphyrias. But another classification of porphyria is, it was also classified as acquired and inherited. So inherited means there is a metabolic defect in the enzyme of the synthesis, that is heme synthesis enzyme deficiency. Whereas acquired porphyrias are those which are acquired because of some tumors, drugs, toxins and so on. And acquired porphyrias are more common than inherited porphyrias. So there are two types of classification. One is erythropoietic and hepatic depending on the site, and other is inherited and acquired depending on the metabolism that is responsible. So coming to the types of porphyrias. Now deficiency of enzyme ALA synthase actually doesn't come under porphyria, but it is known as sideroblastic anemia, but it is related to the heme synthesis pathway, so we take it under porphyrias. So in sideroblastic anemia, there is deficiency of enzyme ALA synthase. So that is, ALA synthase is required for the conversion of succinyl-CoA and glycine to delta amino levulinic acid. So deficiency of enzyme ALA synthase is known as sideroblastic anemia. It is an X-linked inherited disorder, and mainly symptoms will be anemia. So this is the first, that is sideroblastic anemia. Now second, that is deficiency due to enzyme ALA dehydratase. So ALA dehydratase deficient porphyria, that is second type of porphyria. So ALA dehydratase is required for the condensation of this two molecules of ALA to porphobilinogen, and this enzyme is required here, that is ALA dehydratase, and deficiency of it leads to ALA dehydratase deficient porphyria. Now coming to the third and one of the commonest type of porphyria, that is acute intermittent porphyria. So acute intermittent porphyria is due to deficiency of this uroporphyrinogen 1 synthase. Now where this uroporphyrinogen 1 synthase is required? It is required for the conversion of porphobilinogen to hydroxymethylbilane. That is, it converts this porphobilinogen into the linear structure, that is hydroxymethylbilane, and this enzyme required here is uroporphyrinogen 1 synthase. So deficiency of this will cause acute intermittent porphyria. Now what will be the symptoms in this acute intermittent porphyria? There will be accumulation of the precursors because the deficient enzyme is deficient here. So the precursors are ALA and PBG. So they will get accumulated in various organs of our body. That is ALA and PBG will get accumulated. And the symptoms most commonly are neuropsychiatric symptoms and abdominal pain. So that is because of the accumulation of ALA and PBG. That is because of the neuropsychiatric symptoms. That is, if brain is involved, then there will be convulsions, confusions, and anxiety. So there will be different symptoms related to neuropsychiatric disorder. Now why this neuropsychiatric and abdominal pain occurs? It is said that this ALA and PBG that inhibit the ATPase. So because of that, there is inhibition of the nerve conduction, or there is nerve conduction paralysis. So paralysis of nerve conduction may lead to the symptoms, that is neuropsychiatric symptoms, and also to abdominal pain. So vomiting, abdominal pain. So symptoms of abdominal pain may occur in case of porphyria because of the inhibition of nerve conduction due to inhibition of ATPase. So that is the main features of the causes of the symptom in case of acute intermittent. And the name also suggests intermittent. It means the symptoms occur on and off. Therefore, it is acute type, intermittent, and porphyria because there is accumulation of ALA and PBG. So now there is synthesis of this hydroxymethylbilane, and it can get converted spontaneously in the presence of light to uroporphyrinogen, and in the presence of uroporphyrinogen 3 synthase, it gets converted to uroporphyrinogen 3. So next porphyria, that is congenital erythropoietic porphyria. That is due to deficiency of enzyme porphobilinogen deaminase or uroporphyrinogen 3 co-synthase. That is, this 4 molecules of, that is the hydroxybilane which was formed after porphobilinogen, that hydroxybilane in the presence of PBG deaminase gets converted to uroporphyrinogen 3. And this deficiency of this enzyme leads to congenital erythropoietic porphyria. So what happens in congenital erythropoietic? Now this is the autosomal recessive porphyria. Now remember, all porphyrias are autosomal dominant except this congenital erythropoietic porphyria, which is autosomal recessive. And the symptoms will be, now after the synthesis of this uroporphyrinogen, that is from now onwards the symptoms of photosensitivity will develop. So when the PBG co-synthase or deaminase deficiency, person generally in congenital erythropoietic porphyria will have photosensitivity. So if the teeth are also exposed to ultraviolet lights, they will shine or emit light, that is known as erythrodontia. So this is common in congenital erythropoietic porphyria. Now why there is photosensitivity in case of congenital erythropoietic porphyrias? We have seen that in this case there is already synthesis of porphyrinogen. So this porphyrinogen gets converted to porphyrin when it is exposed to light. So after light, when it is accumulated in the skin and the tissues of the eye, there is generally photosensitivity because after ultraviolet light exposure or exposure to sunlight, it gets activated. and this activated porphyrins will irritate the light and skin. Now, why also skin lesions are present in case of congenital erythropoietic porphyria? It is said that when sunlight is exposed, skin is exposed to sunlight, then there is formation of reactive oxygen species in the skin because of this active porphyrins. And this reactive oxygen species causes lysosomal damage. It causes release of lysosomal enzyme, which causes the skin lesions. So there is more and more synthesis of reactive oxygen species because of these porphyrins when exposed to ultraviolet light. So the skin lesions and photosensitivity is because of this reduction of reactive oxygen species. And because of the ultraviolet light, it gets activated. So these will be the symptoms in case of congenital erythropoietic porphyria. The four main symptoms are photosensitivity and skin lesion. So the skin appears, after repeated exposure, it will appear as werewolf-like skin, and there will be photosensitivity. So this is because of the production of reactive oxygen species in case of congenital erythropoietic porphyria. Now coming to Porphyria cutanea tarda. This is also one of the commonest type of porphyria, that is Porphyria cutanea tarda, and it is because of the deficiency of enzyme uroporphyrinogen decarboxylase, which is required for conversion of uroporphyrinogen 3 to coproporphyrinogen 3. So now here uroporphyrinogen is getting converted to copro. So what is the difference? This methyl group is now replaced. So first there was acetyl group in case of this uroporphyrinogen, which is replaced by the methyl group in case of coproporphyrinogen. So there will be MP, MP, MP and PM. PM because it is of 3 types. So 3 series are most commonly found in our body. So we continue with the 3 series. So uroporphyrinogen gets converted to coproporphyrinogen, where the acetyl group is replaced by the methyl group. And the enzyme required is uroporphyrinogen decarboxylase. So in Porphyria cutanea tarda, the deficient enzyme is uroporphyrinogen decarboxylase. So this enzyme is deficient and the symptoms will be same, that is photosensitivity, skin lesion and various neuropsychiatric and abdominal symptoms. And so mainly skin lesions are seen in case of Porphyria cutanea tarda. So we have already seen why these skin lesions occur, because of increased activity of the reactive oxygen species. There are skin lesions. So we have seen the up to this enzyme deficiency, that is uroporphyrinogen decarboxylase. Now this, if the enzyme deficient is porphobilinogen oxidase, it leads to hereditary coproporphyria, which is required for conversion of coproporphyrinogen 3 to protoporphyrinogen 3. So this enzyme, if it is deficient, that is coproporphyrinogen oxidase, it leads to hereditary coproporphyria. If the enzyme deficient is protoporphyrinogen oxidase, it leads to variegate porphyria, that is this oxidase is required for conversion of protoporphyrinogen 3 to protoporphyrin, that is oxidase enzyme, and the porphyria is variegate porphyria. And for the conversion of protoporphyrin to heme, the enzyme required was heme synthase or ferrochelatase, and the porphyria, that is due to deficiency of heme synthesis enzyme, it is known as hereditary protoporphyria. So, and the symptoms will be same, that is neuropsychiatric disorders, photosensitivity, abdominal pain and so on. So these are the various types of porphyrias. So one was acute intermittent, second is congenital erythropoietic, Porphyria cutanea tarda, hereditary coproporphyria, variegate porphyria and hereditary protoporphyria. So we have seen all porphyrias are autosomal dominant except the congenital erythropoietic, which is autosomal recessive. Whereas all the porphyrias are hepatic porphyrias except congenital erythropoietic and this hereditary protoporphyria, which is erythropoietic porphyria. Rest will be hepatic porphyrias except these two. So this is the porphyrias. So we have already seen porphyrias, acute intermittent enzyme deficiency was uroporphyrinogen 1 synthase. Symptoms were, so mainly there is accumulation of ALA and PBG. So in this case, photosensitivity will not occur as porphyrinogen is not formed. So abdominal pain and neuropsychiatric symptom. But after this, photosensitivity and the skin lesions are the common symptoms. That is in case of porphyria cutanea tarda, which is due to deficiency of uroporphyrinogen decarboxylase, hereditary coproporphyria, variegate porphyria, also same symptom, congenital erythropoietic porphyria and protoporphyria. So what happens in porphyrias? There is mutation in DNA, abnormalities of the enzymes of heme synthesis. So there may be two types. First, due to accumulation of ALA and PBG and decrease in heme in cells and body fluids. So the symptoms are neuropsychiatric. We have already seen how the neuropsychiatric symptoms occur. And second is due to accumulation of porphyrinogen in skins and tissues. So there will be photosensitivity and skin lesions in second type of porphyrias. Now coming to diagnosis of porphyrias. Now in case of ALA dehydratase deficiency porphyrias, what are the laboratory findings? Urine ALA will increase, urine PBG will be normal and RBC will be normal. In case of acute intermittent porphyria, because of deficiency of deaminase enzyme, urine ALA will be increased, urine PBG will be present and plasma porphyrins will be normal. In case of hereditary coproporphyria, urine ALA will be normal, urine PBG will be present and plasma porphyrins are normal. In case of variegate porphyria, urine ALA is normal, urine PBG is markedly increased and urine porphyrins are present and plasma porphyrins are also present. In case of porphyria cutanea tarda, RBC uroporphyrins are present, plasma uroporphyrins will get and urine uroporphyrin will also be positive. In case of CEP, RBC uroporphyrin and coproporphyrin will be positive, plasma uroporphyrin and coproporphyrin will be positive and urine uroporphyrin and coproporphyrin will also be positive. Whereas in case of erythropoietic porphyria, RBC protoporphyrin will be positive, plasma porphyrin and urine porphyrin. So we can do the test for urine and blood and see which precursors are increased in case of urine and plasma, and that's how we can diagnose the various porphyrias. Now coming to some types of acquired porphyrias. Now when this what are the causes of this acquired porphyrias? One is ethanol and lead poisoning or some malignancies which will inhibit the PBG synthase and ALA may accumulate in the body. In case of certain tumor malignancies, HMB synthase will be inhibited, which will lead to accumulation of PBD and ALA. So symptoms will be accordingly. In case of some chronic renal failure or malignancy, uroporphyrinogen decarboxylase will be affected and uroporphyrinogen will increase in our body. Now, in various liver diseases, in chronic renal failure, in cancers, and lead, mercury, and arsenic poisoning, the coproporphyrinogen oxidase enzyme will be inhibited. So, these are the acquired porphyrias, which will inhibit the various enzyme or pathway, and the symptoms will be of porphyrias. There will be accumulation of porphyrins or its precursors in our body. Similarly, there will be iron deficiency anemia, lead and aluminum poisoning, which will inhibit the ferrochelatase enzyme. So, these are the various types of acquired porphyrias which will inhibit the various enzymes. So, various toxins or lead toxicity or various drugs also which stimulate this ALA synthase. That is the barbiturates, phenobarbital and certain steroids. Also, oral contraceptives can stimulate porphyrias like symptoms in case of women. So, these are the drugs which will mimic the symptoms of porphyrias, and they are known as acquired porphyrias because of the enzymes which will be inhibited. So, diagnosis, how you will diagnose now the case of porphyrias? You have to demonstrate porphyrins, and UV fluorescence is the best technique to diagnose porphyrins. So, the presence of porphyrin precursor in urine is detected by Ehrlich's test. So, Ehrlich's reagent is helpful in diagnosis of urine porphyrins. When urine is observed under ultraviolet light, porphyrins, if present, will emit strong red fluorescence. So, this is how you can diagnose the porphyrias. Also, presence of Soret band. All porphyrins will have an absorption band near 400 nm, and this distinguishing band is called the Soret band. That is, uroporphyrinogen, coproporphyrinogen and protoporphyrinogen have band at 406, 400 and 408 valence respectively. So, these bands will be present in case of porphyrias. Now, what is the treatment? Treatment is generally symptomatic. We can give hematin so that we can supply heme from outside. And also we have seen that the symptoms which are there due to the production of oxidant species, that can be prevented by giving antioxidants. So, beta carotene, vitamin C, vitamin E can be given to the patients. That is antioxidant to minimize or reduce the symptoms of porphyrias. And also the symptomatic treatment, that is if there are skin lesion, or to prevent skin lesion we can use sunscreens when we go in the sun, goggles to avoid the photosensitivity. So, symptomatic treatment can be given, and hematin. And of course, the drugs which accelerate the symptoms have to be avoided, that is barbiturate, and anticonvulsants and steroids. So, these are to be avoided. So, treatment is generally symptomatic. So, what is the summary? Hemoglobin is a conjugated protein having heme as prosthetic group and the protein globulin. Compartmentalization of the enzyme help in its regulation of heme synthesis, and porphyrias are the metabolic disorders of heme synthesis characterized by increased excretion of porphyrins and its accumulation of precursors in the body, which leads to the symptoms of porphyrias. These are the various references. Thank you.